Hello, welcome everyone. We'll give you guys a moment to all cram in the Zoom room here and we'll get started for today's event. All right. Feels like it's been a while since we were together. Welcome everyone to the seventh episode. Can you believe it? This year's flying by of our 2025 webinar series, Mastering Lewy Body Dementia Together. My name is Julia Wood. I'm the Director of Professional and Community Education here at the Lewy Body Dementia Association. And this year, as a lot of you probably know, we've been exploring a range of topics to help you better understand Lewy Body Dementia and its symptoms, also strengthen your ability to advocate for services and support, and pick up new tools and techniques to help you live optimally. Today, our topic is going to be navigating the twilight, understanding the advanced stages of Lewy body dementia. And this is a topic that we get a lot of questions about and a lot of requests come in. So we're excited to tell you more about that in just a little bit. But just to tell you a little bit more about us, our mission here at LBDA is to optimize the quality of life for those affected by Lewy body dementia. To do this, we accelerate awareness, advance research for early diagnosis and improved care, and provide comprehensive education and compassionate support. So a few technical items to review before I bring in our presenter. To launch closed captioning, you can select the closed captions at the bottom of your Zoom toolbar at any time during the presentation. There is also a resources icon that you'll notice in your Zoom toolbar that has links as well as downloadable resources to accompany today's session. If you would like, you can print out the webinar worksheet included in the resources to guide you through how to apply today's information. And you'll also find a link for the slides to accompany today's session as well. You're encouraged to submit your questions throughout the presentation using that Q&A icon. Following the presentation, we will address as many questions as we can from the audience Q&A pool. But as you know, we're probably going to have hundreds of people on this session, so it's impossible for us to get to everyone's question. My colleague Rose will be dropping links in the chat throughout the presentation, and these links will also be in your email inbox in about 1 week from today as part of our post-webinar thank you email. This presentation is being recorded, and an email will be sent to those who registered with a link to view the recording in about 1 week. When you leave the session today, a brief survey will appear asking for your feedback about today's presentation. We would greatly appreciate it if you would take a moment to complete that survey to help inform our content for the remainder of the year. Okie dokie. So then we also encourage you, we're doing these at a clip of about once a month, but in between times, you can keep learning until we see you again in August with our on-demand learning options. So recordings of all of our past webinars from this year and 2023 and 2024 can be found on our YouTube channel, LBDA TV, along with other video content. And so the Lewy Learning Center is another great resource for you to explore in between webinars. And here we offer courses on a variety of topics that you can watch, rewatch, and share with friends and family. Check out our newest course, Redefining Intimacy, with Jori, who's a clinical social worker. And then also, too, a lot of families really like this resource. You can watch and share the film Spark about Robin Williams and his battle with Lewy body dementia and other video offerings on our Mediflix channel. So we encourage you to check all of those resources out. And definitely, if you want to stay up to date on what we've got going on here at LBDA, follow our social media channels to hear about our upcoming webinars and programs. And of course, you can always visit our website at lbda.org for all your other needs. All right, and with that, I'll stop sharing and we'll find out who's with us, learn a little bit more about you guys. And so we're going to launch our first polling question here. Rose is going to do that. So our first question here is, how long have you been either living with LBD, and that could be a care partner or someone with Lewy body dementia? If you are a researcher or advocate or healthcare provider, how long have you been treating people with Lewy body dementia? And we give you the options here of 0 to 3 years, 4 to 8 years, 9 to 15 years, and also some of you might even be more than 15 years. So let's see. We've got almost everybody in here, and people keep pouring into the Zoom room. This is fantastic. All right. So I'm going to share these results out here. You'll notice kind of running neck and neck between, we've got almost half of you, 45%, between 0 to 3 years. And then we've got 43% of you, another for 4 to 8 years. And then a little less in that 9 to 15 or more than 15-year column. So thank you so much for that. All right, so one more question, and this really helps our presenter, just so you know a little bit more about our audience. So how knowledgeable do you feel you are with today's webinar topic? So some options here, you notice this topic's really new to me. You might feel like you know a little bit about this webinar topic. You might feel very knowledgeable about the topic today, or consider yourself an expert in this topic when we're talking about advanced stages. All right, so I'll give you a second here to do that one, and we keep pouring more people in too. Great numbers. I had a feeling we'd probably be seeing a lot of attendees today. Just to let you know, this was our highest number of registrants ever for one of our webinars here. So super excited for today. All right, so I'm going to go ahead and end this poll and share the results here. So you'll notice we've got about 20% of you where the topic is pretty new. Majority of you feel like you know a little bit about this topic. And then we've got a few of you that feel very knowledgeable. And then we don't have anyone who considers themselves an expert. And I have to admit, Dr. Fleischer, our guest today, may not even consider herself an expert at such a complicated topic, but we definitely consider her one. So I'll stop sharing there. And with that little vignette, I'd love to introduce our presenter today, Dr. Jori Fleischer. She is a movement disorders neurologist at Rush University Medical Center, where she leads several care and research programs focused on Lewy body dementia and related conditions. She is dedicated to improving quality of life for people facing complex neurologic disorders through compassionate care, advocacy, and research. With advanced training in neurology, palliative care, and clinical research, Dr. Fleischer helps develop new ways to support individuals and families navigating LBD. Her work is supported by national research grants and foundations, and she actively mentors others in the field. Please use your reactions, LBDA family, to warmly welcome Dr. Fleischer. Welcome, Dr. Fleischer.
Thank you so much, Julia. And yes, I 100% agree. I every single day in clinic, I feel like there's more and more for me to learn about this topic. So I would not consider myself an expert, but I am so floored by the number of people joining and the number of registrants. So huge thank you first to LBDA for offering this series and naming this topic as something that needs to be out there. And to everyone who is live and watching this, thank you. We know that you are so, so busy and there are so many other things that you could be doing. And this is a scary sounding topic. So kudos to all of you. Thank you, Julia. Thank you, Rose, everyone behind the scenes.
Thank you. Take it away. We'll be in the backstage.
All right, let's see if I can share this and we'll get going. All right, so hopefully that's up and running. See if I can see everything on my screen.
Looks good.
All right. So we're going to go ahead and we're going to talk about navigating the twilight, understanding the advanced stages of Lewy body dementia. And just a shout out that if you haven't checked out the other talks in this series, please, please, please do, including Dr. Melissa Armstrong's fabulous talk on palliative care. A lot of that overlaps with what we'll talk about today. So here is what we're going to aim to take away by the end of this session is to understand, I would say, some of the symptoms and progression of advanced Lewy body dementia. We couldn't possibly cover it all, let alone in an hour. We're going to talk through some effective communication and behavioral strategies. We'll talk about some practical tips for daily care, and then planning for and what to expect as we approach end of life in Lewy body, some resources and support networks. And then before we move on to there, we will launch another poll because Rose is awesome and she is in the background. So I know we had very few people who said that they were an expert in this, but people who said that they had some familiarity with this topic. So we'll launch the poll to see how often have you discussed end-of-life concerns with your loved one's healthcare team? The options are never, and I'd prefer not to. Though your being here kind of suggests that we might not have as many people answering that. Never, but I'd like them to start the conversation, meaning the healthcare providers to initiate that conversation. We've talked about it once or twice, or we've talked about it at least 3 times. You're all so speedy. Thanks for answering. Let's see. Last few stragglers. Perfect. So lots and lots of good answers. So a handful of people, 7% said never. We've never discussed this and I prefer not to. And you are not alone, right? This is a really difficult topic to think about, to bring up. And so I just want to acknowledge and validate that so many people go through and don't ever talk about this. So kudos especially to you all for being here. This is the beginning of the conversation. 38% said we've never talked about it with a healthcare provider, and I'd like them to start the conversation. 35% have talked once or twice, and 21% have had discussions about end-of-life care at least 3 times with their healthcare provider. So it's a really good range. Awesome. Thanks so much. So let's start. We'll start by talking through some symptoms and progression. And so hopefully this may be old news to many folks, but if you're just joining, if this is your first Lewy Body webinar, you chose a great one to jump in on. But let's talk about what is Lewy Body dementia, okay? And so this is one of my very favorite analogies. I really love stupid analogies, so bear with me. But Lewy body dementia is a very confusing term. It's confusing to people living with the diagnosis. It's confusing to care partners. It's confusing to healthcare professionals and researchers, okay? So it is an umbrella term under which there is a chicken and an egg, okay? So this is my chicken and egg under an umbrella problem. And here's what we mean is there is this group of symptoms that we call Parkinsonism. Okay, so slowness of movement, stiffness of the muscles, plus or minus a tremor. Not everyone has a tremor, and changes with balance and posture. And if you have the slowness, the bradykinesia, and at least one of those other 3 things, we say that that person has Parkinsonism. Okay, they're in that zone of Parkinsonism. And for the purposes of this very stretched analogy, Parkinsonism is our chicken. Okay. And then although the term dementia is actually a very broad term, and it means that there is a progressive decline in areas of a person's memory and thinking to the extent that it's impacting their daily life. When people hear dementia, they often think Alzheimer's. So they think about someone repeating themselves in conversation, kind of forgetting stuff going on around them, short-term memory going, and then long-term memory. That's not all forms of dementia, and it's certainly not Lewy body dementia. Because what we mean when we're talking about dementia are changes in attention, concentration, decision making, or what we might call executive function, multitasking, things like that, and visuospatial processing. And as opposed to Alzheimer's, where there may be good days, there may be bad days, but in general, things are fairly steady. In this form of dementia, there are these hallmark fluctuations, meaning a person with Lewy body could be having a conversation, they're spot on, they are, talking about their career, they're talking about what they just, movie that they just watched, they're great. And 5 minutes later, family can almost point out, often they'll describe, I see this hand motion all the time, is just this fog comes over the person. And the person may recognize it and be able to say, I'm just having a moment. Words are harder to get out. The logical flow of ideas is more challenging. The person may seem more sleepy or just have less energy. And those fluctuations can happen on a moment by moment basis. They can happen numerous times per day, and they're not under the person's control. It's kind of like there's a dimmer switch in the brain and someone is just accidentally bumping up against it. Those fluctuations are a key piece of this form of dementia, and hallucinations, where someone is seeing something most often that isn't truly there, but also that could be hearing something that isn't there, a loved one calling for them from a different room, or hearing a door knock that isn't really happening, feeling something, or even smelling or tasting something. So if someone has this group of symptoms, this flavor of dementia, okay, we're going to think about that as our egg. All right, Parkinsonism chicken, this dementia egg. So here is the confusion. If someone develops Parkinsonism first, they're typically diagnosed with Parkinson's disease. And at some point down the line, 5, 10, 15, 20 years later, they develop this flavor of dementia. We say that that person has Parkinson's disease dementia, or PDD. However, not everyone read that textbook, okay? So some people develop the dementia symptoms first. And then at some point down the line, they start to have slowness. They're shuffling as they're walking. They might have a little bit of a tremor. They're starting to get bent over. They develop the Parkinsonism later. Or they all start at the same time or within a year of each other. There's this 1-year rule. So if the dementia comes first and the Parkinsonism comes later, or the dementia and the Parkinsonism are starting together, we say that that person has dementia with Lewy bodies. And if that's not confusing enough, whether you've got the chicken coming first and then the egg coming first and then the chicken, or they both show up in the basket together. If you've got both the chicken and the egg present, the Parkinsonism and this dementia, we group those together and say the person has Lewy body dementia. And this is super confusing because, Jori, isn't that just the same words of dementia with Lewy bodies scrambled in a different order? Yes, it is. Okay. But what this means is if your loved one has Parkinson's disease and someone has now said, well, they've had Parkinson's for all this time and now they have Lewy body dementia, it's not really another diagnosis. It's part of that disease journey. Okay. Hopefully that's cleared up a little of the confusion. The next thing that often comes up is, what stage am I at? What stage is my loved one at? And the takeaway here is there is no agreed upon staging system in Lewy body dementia, period. I looked online just because I'm always curious, and people come in and they bring all kinds of things all the time. They're like, on this staging system, where am I? And I go, I've never even heard of that. And this is what I do, right? So here's one graphic that I found online that informed me as a Lewy body person. This is the progression of Lewy body dementia. And the challenge is, this says in early stages, people have delusions, restlessness, REM sleep disorder where they're acting out their dreams, movement difficulties, and urinary issues. And then later, they have motor impairment, which is a synonym for movement difficulties. And they have significant confusion. I don't even know what that means. And decreased attention. But that has to be there to make the diagnosis. So all I have to say about this is not a thing. This does not help us because it's just naming symptoms in random order, but these symptoms can happen in random order for any given person. So this staging system doesn't help us. There's this other one. So people talk about the 7 stages of dementia. This is actually part of the FAST scale. And I find this fascinating and infuriating. Because the scales of cognitive impairment here are stage 1, no cognitive impairment. I don't feel like someone should be labeled as having cognitive impairment and then a stage 1, no cognitive impairment. So I find this very hard to kind of parse with Lewy body dementia, but this basically just goes from none, very mild, mild to medium, but without actually having any anchors for what does that mean? And if we don't have anything to say, what does that mean? Then this staging system is meaningless, right? And so I wish, and very smart people are working on staging systems in Lewy body dementia. But because this condition is so variable, everyone is, progressing through it in their own individual way. And so as challenging as it is that we can't say on a 5-point staging system, you're at this point, I think the more important thing is to talk with your healthcare providers about what symptoms are going on, what we can do about them, and what this means next. What do I plan for? What should I anticipate? That we can try to do. Because here's what we know is gradual progression should be the rule. Okay, so I often joke that in Lewy body dementia, one of the main issues is that the brain cells that are producing dopamine, they're not unionized. Okay, they don't go on strike. right? This is a slowly progressive condition where things are changing over months and years. So I took this from this article here that came out in 2022. This is a graph that just shows us over time, from the time that someone actually was told that they have Lewy body, what is the progression of clinical features. Okay. And this is not in any given one person, but it says basically over time, the chance that someone has Parkinsonism is kind of the highest thing, that they've got some movement symptoms, which makes sense because probably Lewy body wasn't even thought of as a diagnosis unless that person had some Parkinsonism. And then very common that they've got REM sleep behavior disorder at the outset, acting out their dreams during sleep, really, really vivid dreams and shouting, kicking, thrashing, punching. And then as time goes on, we start to see those fluctuations, the moment by moment kind of dimmer switch. And as time goes on, the longer we follow people out, the higher these lines go, the higher chance that any given person has that symptom. So highest chance that they've got some movement issues and the REM behavior disorder, the sleep issues, hallucinations, and then fluctuations. These are gradually increasing over time. What this other graph shows us is gradual changes in different areas of memory and thinking. So what we see is as time goes on, the sharpest decline here is in attention. So a person's ability to shift their attention, if they get interrupted by something, can they respond to that thing and then go back to what they were doing? Or is it really, really hard to kind of get right back into it? That is a huge challenge in Lewy body. That's something that changes early and significantly. And so it makes sense that we see this orange line of attention really taking a dive quickly. But the other things are much slower in progression. So changes in visuospatial function is that red line, changes in memory is that black line, language and executive function. Those are changing, but at a much, much slower pace. And you see that these don't ever form a cliff, okay? However, I hear this all the time but what if I wake up one morning and I am here to tell you that if those graphs didn't help convince you, there is no wake up one morning and Lewy body has suddenly changed. Okay. Like I said, those dopamine neurons, they don't go on strike. All right. But it feels like, and it certainly feels like to us as the healthcare providers, my nurses for sure, Friday afternoon at 4:30, everyone wakes up that day and, right? Something is going on. There is an abrupt change in the person with Lewy body's mobility. The meds are suddenly not working. They're freezing all of the time. They're falling and they weren't falling before, or they used to fall once a month and they've fallen 3 times today. Or they're really confused. I can barely wake them up. Something is going on. Or they've never had hallucinations before and now they are. Or they used to just see a little mouse in the corner, but now they think the SWAT team is coming in through the window. And I cannot convince them otherwise. If that is happening, it is something else. It is always, always, always something else. So most often, it is a urinary tract infection. I'm going to say that for everyone in the back. It is almost always a urinary tract infection. And if we wait until the person with Lewy body says, well, gee, my urine is a slightly different color today. It's a little deeper yellow than it was yesterday, or it burns a little bit when I urinate. We are going to be waiting forever. We're going to be waiting until that person is septic in the intensive care unit or worse. And so this is a huge challenge for care partners, but this is where being really, really observant and being the squeaky wheel is absolutely what is needed. Okay? Because if you see that change in your loved one's neurologic symptoms, you hit the alarm button, you call their primary care doc and say, something's going on. Can we get them checked? Can we get checked for urine? Can we get checked to make sure that there isn't a pneumonia, a cold, a flu, a COVID, a viral something? If they've been eating differently or they have any history of dental problems, could they have a dental abscess? If they have diabetes and they have neuropathy, could they have a wound on their feet that we maybe don't notice? Could they have a pressure sore on their bottom or on their heels? That can be a really sneaky source of infection. These cause sudden declines, but it looks like it's the Lewy body. And we always have to figure out, be the detective, be the house, where is it coming from? Constipation. We'll talk about it in a little bit, but constipation is a huge cause for people suddenly declining, winding up in the hospital with a bowel obstruction. Dehydration. And if you are going, yeah, but she doesn't like to drink water. I know all of our Lewy body folks do not like to drink water. Okay. Hydration with anything is better than dehydration, but dehydration is a common reason for people to suddenly change. Medication errors, new medicines that were added, a refill that suddenly changed color, shape, size, maybe is an error on the pharmacy's part. It does happen, unfortunately. Or an over-the-counter med that someone was having a rough night, the arthritis was acting up, and we took a Tylenol PM, we took an Advil PM. The Tylenol, the Advil are fine. It's the PM part of it. The PM is Benadryl or diphenhydramine. And those medications, the PM parts or anything in a cough and cold medicine preparation that says plus severe max flu, anything, they're adding other components into those medications, and those are not safe for people with Lewy body. Also think about any new supplements, any new gummies. Yes, we know that people are taking gummies. We know it. Those could be a source of new confusion, new hallucinations, and things that we need to know about, as well as low blood pressure. So you should not wake up one morning and if you do, think about all these other things, call the primary, get the person tested. We have to figure out why, okay? We're going to move on now to talking about some of the symptoms that we see more often in advanced or sort of later stages of Lewy body, knowing that there are no official later stages, but as the disease goes on. So as a movement disorders specialist, I am trained to hopefully identify the medical factors contributing to someone falling. And freezing of gait is a really common symptom that we see as Lewy body progresses. And what that means is someone gets up, they start to get up out of a chair and they can't take that first step. There's some hesitation there. Or they're walking, they're doing okay, they get to a threshold of a door. Or people walking to the hallway, they were okay when they're on their own, and now all of a sudden they're stuck. Their legs are just glued in place. That's freezing of gait. Or they're walking okay and they try to turn and then they do the little stutter step and turning takes 25 steps. Or they're okay until they get back to the chair to go sit down and then they get frozen trying to sit back in the chair. Freezing is a huge source of falls. So we really want to know that it's going on and we want to identify contributing factors. So if this is a person who is on a dopamine type medication like levodopa or something like it, and we find that they're freezing, but they're only freezing towards the end of each medication dose, that's actually great news because then that tells the doc that they should be adjusting the timing of the doses and we may be able to help there. We want to see if there's imbalance. And if so, I wish that we had a perfect pill for imbalance, but we have physical therapy and it can be tremendously beneficial. Sometimes contributing factors to freezing of gait and to falls are impulsivity. So sometimes folks won't move when we want them to move. We say it's time to get up, you got to do your physical therapy exercises, they won't. And the moment that the care partner goes to finally take a bathroom break for the first time in 10 hours, all of a sudden you hear the loved one get up out of the chair. And maybe they've got enough strength to somehow get up and enough mobility to get up, but then they freeze and that's when they fall, is in those impulsive moments. So we want to think about that and bring that up to their treating provider and so that we can work on that as a cause. Similarly, anxiety. Anxiety is a huge symptom on its own in Lewy body. And if someone is anxious, if they start to become afraid of falling, that physically changes how they move and it makes them more likely to fall. So coping with the anxiety in lots of different ways can be helpful, as can checking to see what's happening with their blood pressure when they start to freeze. Are they at a normal blood pressure and then all of a sudden it dips? Are they freezing right after they eat a big meal when all the blood rushes to their gut and there's not nearly enough blood pressure to sustain brain power and mobility? We want to know about that because we can work on that. We can treat that. We also really want to identify the setting. So people look great in clinic for me all the time. We see this spotlight effect where the person stands up from the chair, they look terrific, they take off down the hall and family is sitting there and going, he never looks like that. That's not what it looks like. And I will tell you that as someone who's done home visits for years, we know. We know that people are showing off, often unintentionally. But freezing happens in rooms that look like this. When there is a tight space, when there aren't grab bars, when people need to turn around in really, really narrow spaces, where there's a lot of clutter or hoarding situations, that can be a big provocation for falls and for freezing of gait. And then multitasking. Multitasking is related to attention. And I already told you attention is one of the things that takes a hit early in Lewy body. So even though we might not think about it, walking down the stairs with laundry looped over our shoulder is multitasking. Walking up and down the stairs while continuing a conversation with someone on the floor above or the floor below is multitasking. And those are risk factors for a person freezing or falling. So we really, really, really don't want to multitask, especially on stairs. So if someone is having freezing of gait or falls, talking with their physician about adjusting their levodopa if they're on it, considering some of the other medications that we have that work in different ways, treating orthostatic hypotension, those drops in blood pressure, treating anxiety if those are contributing, and getting our physical therapy colleagues involved, especially ones who are trained in LSVT, which is a Parkinsonism form of therapy. They're going to be the experts. They're going to get it. You're not going to have to explain what's happening to them. They'll be able to start already at a gold star level and work from there. And then a home safety evaluation. Often these are our occupational therapy colleagues who are the troubleshooters, the fixers. They can come to the home and say, you know what, I see that this is a place where your loved one might be prone to falling. Let's fix this with this simple thing. Sometimes it's as simple as neon painter's tape at a change of flooring or a threshold to cue that person to step over it. Another symptom that is a big red flag, and I bring it up because if we don't do something about it, it's a huge problem, but we can do something about it and prevent certain problems, is dysphagia, which is our fancy word for trouble swallowing. So this figure is a little bit older, but it's taken from a study that looked at 50 individuals with later stage Parkinson's, and they assessed them extensively at baseline, and they followed them out for a year. And what they found was just trouble swallowing alone. Everything else aside, just trouble swallowing alone predicted a poor outcome after 1 year. And they defined a poor outcome as that person reaching a bedbound or wheelchair-bound state, or being placed into a nursing facility, or passing away. If they hit any of those things, they said that's a poor outcome. And this green line, these are the folks who had trouble swallowing on day one, and here's where they were by the end of that year. So I bring this up because our speech language pathology colleagues, there is no point at which they cannot still help. I firmly believe this about physical therapy, occupational, and speech therapy. There is no point at which someone is too far gone to be helped. So asking for a referral for a swallow study, trying to find an LSVT certified therapist whenever possible. How do I do that? I bet Rose can drop something into the links if it's not already in the resources, but there is a website. You can search in your zip code for people who are trained by you. And those therapists can then make recommendations like how to alter the diet. Thickening liquids can often help, cutting food into small pieces, taking small sips of water or a liquid in between bites of food. It sounds simple. It sounds way too easy for this to make a difference. And it absolutely makes a difference. This is the difference between a person being safe at home or being admitted to the hospital with aspiration pneumonia and sepsis and the cycle that goes from there. So maintaining oral hygiene. This is often something that in the 24/7 cycle of caregiving, like really, I'm also supposed to floss, right? But something as simple as just helping your loved one to rinse their mouth and spit if they can after having a meal to clear some of the residue out of their mouth. If we can't, brush our teeth, follow up with the dentist, do all of the usual stuff. Anything that takes some of the crud that could be residual in the mouth and gets it out prevents that crud from accidentally getting swallowed down the wrong pipe and causing pneumonia. If people have a stiff neck and they have a hard time tilting their head up or down, right? A simple thing is someone made probably millions by taking a plastic cup and cutting a wedge out of it. So this is called a nosy cup. You can find it online anywhere. They come in all different shapes and colors. And this means that the person can tip the cup instead of having to tip their head, and just makes things a little bit easier to sip. So there are all kinds of things like that that can really make life easier. Also, if we have trouble swallowing, we are going to have unintentional weight loss. And unintentional weight loss in Lewy body is never the good weight loss that the rest of us want. It is losing muscle mass, which means that that person is more likely to fall. That person is more likely to break something when they do fall and have a more serious injury. Weight loss is associated with malnutrition, with infections, with worse quality of life. And weight loss complicates a person's response to treatment. It complicates their cognitive decline, their blood pressure issues. So first, although I like to blame Lewy for everything, first thing is if someone is losing weight, we want to make sure that they're up to date on their age-appropriate screenings, because people can still have double jeopardy. Just because you have Lewy body doesn't mean that you couldn't also have something going on in terms of cancers, breast cancers, colon cancers, all of those things. So staying up to date on all that usual stuff. We don't want to let our primary care physicians off the hook. They should be checking for all those usual things, okay? We also want to make sure, is the person able to chew? Do they have maybe ill-fitting dentures? Do they have an abscess? Do they have something rubbing up against their gums that's making it hard for them to eat? Are they not swallowing well? Let's get a swallow study. Let's see our friendly dietitian or nutritionist to see what's going on. I think so often we think about, a nutritionist, a dietitian, they're going to come in and they're going to say, you should eat more kale, right? In this setting, our dietitians come in and say all kinds of different things if people are losing weight, and we'll talk about those. But we want to review medications. If someone is losing weight, especially in the setting of a new medication that was started, talk with the prescriber. Could this be causing weight loss? And does the benefit outweigh that risk? We also want to recognize that Lewy body causes changes in a person's sense of smell and taste. So that person's favorite food, that maybe their care partner has been cooking the same way for 40 or 50 years, now they're just kind of pushing it to the side of the plate. That is not a dig at the care partner or their cooking, okay? That is Lewy changing the way that that tastes to that person. So if the person with Lewy starts adding extra seasoning, hot sauce, more salt, things like that, it is not a dig on the person who's cooking. Blame Lewy, okay? We want to adjust their food accordingly. It's also very common that people will develop more of a sweet tooth that they didn't have before. If that's the way that we get in calories, so be it. So if someone with Lewy body is losing weight, I want you to think of it like a math problem, because everyone's brain sends a signal after about 20 minutes of eating that says, I'm full. If you are a teenage boy, you could consume like an entire pizza or two in that 20 minutes. But if you are someone who has mobility challenges, you might only get in a very limited number of spoonfuls or forkfuls before that signal goes off. So if we think of this like a math problem, the number of spoonfuls or forkfuls before that person's brain tells them that they're full is set. We can't change that number. And we can't change how long it takes, right? We can't change that 20-minute window. But what we can change is how many calories, how densely caloric is each spoonful or forkful. So this doesn't mean that if you are the cook, you need to make a totally separate meal. This means you cook whatever you're cooking, but you can doctor the person with Lewy body's serving. So an extra drizzle of olive oil or avocado oil, anything like that, it's 130 calories per tablespoon. Okay, it doesn't actually take a lot to pack in a big difference. Stirring full fat cream or dairy into a soup, a stew, mashed potatoes, pasta, that will add a big sort of dense burst of calories into a small volume. And then extra ice cream. Yes, it's okay. Milkshakes. If you're someone who, will try a nutritional supplement like an Ensure, a Boost, a something like that, that's great. They get boring after a while. Use that as the base of a more exciting milkshake or smoothie. Pour that into the blender, the food processor, throw in some ice cream, some peanut butter, some chocolate sauce, whatever your loved one will eat. Blend it up, make them different. And if there's variety, they may eat it, they'll get those calories. And then that is staving off pressure sores, fractures, muscle loss. Okay. We talked about taking stuff in. We talked about swallowing. We talked about weight loss. No talk on Lewy body would be complete without talking about constipation. Had no idea going into neurology or becoming a mom how much of my day I would spend talking about poop. And here we are. If you are caring for a loved one with Lewy body, you probably spend much of your day thinking about bowel movements and probably did not realize that you were signing up for this. I'm sorry, but welcome. This is a safe space to talk about it all. Okay. So, what is going on is that constipation is happening because the gut in Lewy body is slowing down. All right. It's kind of like a slow moving, if you've ever seen sausage being made, we got to sort of push things through. And that speed of pushing things through slows down. It grinds to a halt. And so stool sits around for longer. And the gut has one job, which is to absorb something from whatever is there in front of it. And if all the nutrients have already been absorbed because this stool has taken twice as long to kind of move its way along, the only thing left to absorb is water, which means that you get this increasingly dry, rock hard stool that is moving and moving and moving and moving. And then I want you to picture that scene from Indiana Jones where the boulder is coming down and then it just gets stuck. Okay? Graphic enough for you. That's what's happening. Is we get this slow moving, rock hard boulder of stool and then build up behind it. All right. And what we need to do for most people is ideally we're preventing constipation, but really for most folks, they're coming in and they're already stopped up. So we need a treatment plan. And then once we get them cleaned out and back to a more normal baseline, then we need a daily plan that's going to keep them there instead of going back through this cycle. Okay. So the things that help prevent are hydration, fiber in food, ideally, rather than a Metamucil or a powder, fiber in fruits and vegetables, and exercise. Movement of the body leads to movement of the gut. In terms of what we have available over the counter, Miralax, which is the brand name, but polyethylene glycol. If you go to the drugstore, it's the one that has the purple cap, not the orange or the green. You are looking for the purple. And usually the store brand is absolutely fine, and the store brand usually has purple on it too. That is our safest and most effective treatment. It will keep working because it doesn't actually get absorbed into the gut, or into the body. It stays inside the gut and it pulls water in to try to flush things out. So the thing to know, and here's my other terrible analogy, is regardless of where you live, I am sure that you have been stuck in traffic at some point recently. There's been a 5-car pileup and you are in the normal traffic behind there that's just stuck. So here's the analogy, is that 5-car pileup is the ball of stool that we need to get out. Miralax is our tow truck. We need to get the Miralax to the 5-car pileup, okay? And there's all this normal traffic, there's all this normal stool that's all there between it, the tow truck, and the 5-car pileup. So what often happens is that the Miralax is going to be absorbed. It's going to soften up the newer stuff first, which may scoot around the ball of hard stool and come out like diarrhea. And that's when people go, she was wrong. We didn't want this. We just wanted normal. And so they stop taking something. But actually, we need to get all of that out. We need to get the normal traffic out of the way so that the tow truck can get to the pileup. All right. So if you imagine being on that highway, you know there's always some dude in a sports car and he is zooming past on the shoulder because he thinks he's special. That is the overflow diarrhea. We are going to ignore him. We are going to stay where we are and keep doing what we're doing and wait for the tow truck to do its job. Okay. I love that everyone is laughing. I hope that this is memorable and it sticks with you. And I'm sorry for the overflow diarrhea, but this is the way to keep people out of the hospital, keep away from having a bowel obstruction. That is not what we want end of life to look like. Okay. All right, there are my terrible analogies. For the sake of time, I'm going to skip over some of these, but I know that Julia has the slides and she will send slides out to you. But is drooling a part of Lewy body? Absolutely. Do we have treatments for it? Yes, we do. We can try sour candies, but if someone is having a hard time with swallowing, we worry about something free floating in their mouth. So a lollipop can be helpful, or our most effective treatment are botulinum toxin injections. The same stuff that people put in their foreheads to make them look younger is actually really, really effective about every 3 months to help reduce the amount of saliva. And that can be a big piece of stigma. It can be the reason why someone with Lewy body doesn't want to go out of the house or go to the family event, is because they don't want someone seeing them like that. That is fixable. It is fixable. And yes, Medicare covers it. Um, Runny nose can often go with the drooling, especially around meal times. Not a perfect treatment, but there is a nose spray out there that sometimes can help. Similarly, people can have both drooling and dry mouth and really dry phlegm that gets stuck and is hard to cough up. Seeing the speech language pathologist, seeing a swallow evaluation can be helpful here. Sometimes having different breathing devices, we can try those things. There is an over-the-counter product called guaifenesin. That is the active ingredient in Mucinex. That is the active ingredient in Robitussin. But again, has to just be plain guaifenesin without the DM, the max, the plus, the blue, all of this. That can be really helpful for phlegm, and people can be on guaifenesin long term. Sometimes saline nebulizer treatments. Sometimes we've heard of over-the-counter papaya enzyme. Papaya fruit is actually great for constipation too, but papaya enzyme may help with some of these thick secretions, and sometimes a suction machine can be helpful. I've mentioned orthostatic hypotension a few times. So this is a common cause of falls, of fatigue, of immobility. And often the person might not be able to describe it. And it's very hard at times to say, well, are they just kind of graying out because their blood pressure just dropped? Are they having one of those cognitive fluctuations? Sometimes we don't know. The only way to kind of tease this apart is to check blood pressure in the middle of this and see whether they're running really low. We want to review meds. A lot of people have high blood pressure for big chunks of their life. But as Lewy body, as Parkinson's progresses, it actually lowers blood pressure on its own. And so the set it and forget it, they've been on metoprolol for years and years, you actually may be able to graduate off of that. And that alone, taking away something that's actively lowering blood pressure, may be enough. And as much as we worry about high blood pressure, the risks of high blood pressure are increasing risks of stroke and heart attack in the next 10, 20 years. But the risk of someone having a blood pressure of 90/40 or lower, or dropping their blood pressure by 30 points when they stand up, that is a clear and present danger. That is a risk of that person standing up, falling, hitting their head, and winding up in the ICU with a bleed. So sometimes there's a shift in expectations that needs to happen about we may need meds to bump up our blood pressure, and we're going to be okay seeing a number of 140 or 150 or even 160 if that means that we're not seeing numbers of 80/40. Okay. So simple things that can be done at home when the person is sleeping, elevate the head of their bed. That can be helpful. Blood rushes to the gut after a big meal. That's why everyone feels tired after Thanksgiving. It's not the tryptophan in the turkey. It's the fact that you ate twice what you usually do and your body is trying to process it, okay? But that happens to people with Lewy body, even with a normal sized meal. So smaller, more frequent meals, not reducing the total calorie intake, but spreading out those calories into more snack-ish meals throughout the day. That can be helpful, and sitting down in the shower. Blood disperses. It tries to go out into the skin when people are in the shower. That means less blood is available to go to that person's brain, and they are more likely to fall, and falling in the shower is never a good idea. I want to talk briefly about pain. So pain is a common and bothersome symptom. It's something that doesn't get talked about nearly enough. There are multiple different kinds of pain that can occur in Lewy body, and it can be very tricky to recognize, especially if the person struggles with articulating what's going on. So watching to see, is there a particular time of day when your loved one with Lewy gets really agitated, especially if this is around transfers, getting up from the bed to the chair, chair to the toilet. If that's when they start to get really agitated, if they're grimacing, if they're groaning or moaning, that may be a sign that they're in pain. And then we just have to sort of be a good sleuth and figure out where is it coming from. And there are many things that we can do to treat pain in Lewy. So this usually takes a multidisciplinary approach: physical therapy, exercise, trying to prevent contractures where the muscles get fixed in a position. But something that is so often overlooked and feels like it's too simple and it's too easy to work, but we have proven that that's not true, is go to your local Walgreens, CVS, wherever. Okay. Go to the pain control section, skip over the oral medications for right now, go to the tubes and all of the preparations. There are three categories that I think about. There's the stinky category. So these are Bengay, Icy Hot, Tiger Balm, Biofreeze, all of those. Okay. Capsaicin and menthol. Pick a stinky. Pick something like diclofenac or Voltaren. That's basically an NSAID, a nonsteroidal anti-inflammatory like Advil or Motrin, but in a gel form. That works differently than the stinky ones. And a lidocaine type preparation like a Salonpas or something like that. These are three different ways of approaching pain. And if you know that your person experiences pain, whether it's arthritic, whether it's something else going on, instead of waiting until the pain is an 8 or a 10 out of 10, put them on a schedule where you pull from these three categories around the clock. You can alternate. So at 8 a.m., you rub on the Biofreeze. And then at noon, you rub on the Voltaren gel. And then at 4, you use the Salonpas. And at 8 p.m., you go back to one of the other ones. You can put these on a schedule and it makes a difference. We'll talk briefly about hallucinations and aggression. So hallucinations are very, very common in Lewy body, and these can range from just a sense that someone is in the room who isn't, to seeing something, a little flutter of color, a mouse in the corner, a bird on the windowsill, to really complex, scary, recurrent things. The group of people that's in the dining room and why won't they leave? Who are they and what are they doing here? The people who are in the basement with nefarious plots, right? This can often, especially if people have a hard time verbalizing it, or if family keeps telling them there's nothing there. There's nothing there. Okay, see, there's nothing there. You're fine. That can often be a source of aggression because to the person with Lewy, their brain is telling them that that is real. And so what we know is in one study, they found that physical aggression happens in about 65% of people and sexual aggression about 27% of people. So this is a really important symptom to think about and goes with delusions. Delusions are not seeing something that's not there, but believing something that is false. So people with Lewy body can have paranoia. It can be general. It can be specific. There's one particular form called delusional jealousy, which is where despite all evidence to the contrary, the person with Lewy is convinced that their significant other is cheating on them. I want you to hear this if you are a care partner. You are not doing anything that is making them think this. You are not doing anything. There is nothing about your behavior that has tipped them off to think this. This is a Lewy body symptom. It's not their fault. It is not your fault. It is Lewy body's fault. Okay? They may not be able to tell you this. They may just get very suspicious, very agitated every time the plumber calls, every time your son-in-law shows up, whatever that is. The other is Capgras syndrome. Again, the person might not be able to verbalize this, but you show up and they say, when is the real Judy coming? You're not the real Bob. When is Mike coming home? And as Mike, you're standing there and you're like, what? Who else would be here? I'm your person, right? So it's this belief that someone, usually the person closest to them, or something, often the bedroom, their house, has been replaced with basically an exact imposter or lookalike. So sometimes people will say, when are we going home? And you're like, we are home. What do you mean, when are we going home? And people often think, do they mean their childhood home? Like they haven't been there in 50 years. I don't understand. It's that we think this is happening because there are changes in the visuospatial processing. And so if anyone has ever heard of the uncanny valley phenomenon, where something looks pretty close to something else, but it's just off by enough that it kind of gives you the heebie-jeebies. If you've ever been to Times Square in New York and you've seen the characters, like there's a guy who's supposed to be Elmo, but that character clearly is not Elmo. It's Weird Elmo, right? And it's a little disconcerting. That's the closest that I can imagine to what this feels like, is something is distorted in how their brain is processing who they're seeing or what they're seeing. And they know that that should be their loved one, but it's just a little off. And that can cause agitation and confusion. And these symptoms independently increase the risk of a person being hospitalized, being institutionalized, having excess caregiver strain. And this leads to a vicious cycle because people with Lewy body are prone to these symptoms, to psychosis. They get agitated because it is terrifying. They can become aggressive. It is terrifying and it leads to a ton of caregiver strain. And so you bring them to the hospital and the hospital does not understand Lewy body and they say, the person's having hallucinations. I will give them medications for hallucinations, not realizing that we need to choose very carefully because their go-to medications that they reach for are toxic to people with Lewy body, especially at usual doses. And so then the person becomes much more immobile, much more confused. And then they have an aspiration pneumonia. And then everything sort of spirals from there. For the sake of time, I think I'm going to skip over sleep disorders, but I will say, yes, Lewy body screws with sleep in every possible way. And yes, there are things that we can do about it. So talk with your healthcare provider. So we've covered a lot of symptoms, and this is just supposed to be a piece of the talk, but I will say that although there are many symptoms, I'm just snapshotting this chart from a recent publication. This is just a highlight of some of the symptoms, just to show you that for all of these things, there are many things that we can do, both medication and non-medication strategies. So bring them up, talk with your healthcare provider, ask what we can do, okay? We're going to move on to talk about effective communication and behavior strategies. This is just skimming the surface, but apathy is a huge symptom. Some days it feels like this is the symptom of Lewy body, is the care partner says she's depressed. And if I say, okay, do you feel sad, blue, hopeless, worthless, guilty, all of the depression questions? No, just right? They know the things that they should do. It's just like someone has poked a hole in the motivation gas tank and it's all drained out. And what this leads to is care partners going, but you have to. The doctor said you need to do this. You're supposed to go to physical therapy. Why aren't you listening? You're supposed to eat this. I need you to drink things. You haven't had anything. And the person feels like they're being stubborn. They're being resistant. They're not appreciative of how hard the caregiver is trying to help them with these things. But that is apathy. So I wish we had a pill for this. We don't have a pill for this. What we have is working on a structured, familiar environment and a daily schedule. Often our occupational therapy colleagues can be fantastic at finding adapted versions of previous hobbies or activities. Maybe they can't go in the garage and work on the car the way that they used to, but maybe there's something similar that they can do. Maybe they can supervise a family member working on the truck and offer suggestions, even if it's harder for them to actually do that physical work. One thing that our fantastic social workers often brought up is the choice should not be, do you want to do this or not? We should offer choice with guardrails. So what does that look like? Instead of saying, do you want to, it's time to, you have to, should we paint now or should we do some stretches? We're going out to eat today. Hooray, it's happening. Should we go to Bob's Diner or Mary's Cafe? The therapist is coming. Do you want to wear the red shirt or the blue shirt? So they still have choice. They still have independence. You're honoring their autonomy as a person, but you're also setting things up that we are going to do these things that you need to do. And here's where you get some choice in that. And often that can be helpful. It's not perfect, but it's a strategy to try. Recognizing that that apathy, just like the delusional jealousy, just like the other things, it's not your loved one. This is not them. This is Lewy. So if you want to be angry at the apathy, please do. Please scream, swear, punch a pillow, go scream, go do something, right? Yell at Lewy without yelling at the person with Lewy. One of the other things, and often this makes apathy worse, is that coping with excessive daytime sleepiness. Lewy messes with sleep in every possible way, and it tries to shift people to being awake all night, asleep all day. That is bad in all kinds of ways. It accelerates the progression of dementia. It accelerates caregiver strain. It is just not okay. It means that they can't go to physical therapy because there isn't physical therapy sessions at 3 a.m., right? So trying to maintain a circadian rhythm, getting them on a daily predictable schedule of activities, keeping lights on during the day, lights and TV and screens off during the night. And when possible, if the person just kind of sits in the recliner all day long, bringing in extra help, extra people, whatever that looks like, to say if 1 o'clock is when they typically doze off, you know what? At 1 o'clock, we're going to turn on Jeopardy reruns and we're going to watch that together. Or I have a neighbor who's got nothing to do and they're too busy telling me what's wrong with my garden. Hey, bud, would you mind coming over at 1 o'clock and watching Jeopardy with my loved one? I remember you saying you like that. Engage your community to do those kind of things. It should not, it cannot all be on any one care partner. But finding ways to take those pieces of the day when the person tends to kind of nap, minimizing the opportunities for naps, especially late in the afternoon, will help reset that clock. And if their sleep schedule is reversed, recognize it did not happen overnight. We're not going to fix it overnight. It's going to take time to gradually try to kind of claw back being awake during the day and sleeping at night. What do we do with those delusions and hallucinations? And I mentioned this a little bit, but there are a couple of R's to think about. What do? We reassure the person. That doesn't mean, yes, the SWAT team is coming in through your window. That means, you look really scared, but I promise you're safe. You are safe here. I'm with you. That's the kind of reassurance that we mean. Redirect or distract, which means if the person is like, oh, I didn't know that Barnum and Bailey was coming to our backyard. That's really nice that they set up the things. If you don't want to engage with that, go, oh, you know what? But actually, they're leaving tonight. They go out of town. So let's go get a snack. Whatever that is. Okay, that's happening. Let's go do something else. Or, the teenagers are back in the dining room again. Don't worry, I told them they have to leave in 5 minutes. In the meantime, let's go to the bathroom. Whatever it is, sure. And let's go do something else. Okay. And if during non-agitated, non-hallucination moments, you're able to practice relaxation techniques with a loved one, you may be able in those moments when they're scared or they're seeing something to call on those techniques. If they're not being practiced beforehand, they are not going to suddenly do yoga when they're seeing a hallucination, but they may be able to take a deep breath if they've practiced taking a deep breath when they're not stressed. I think the other thing to think about is, and we hear this a lot, is people say, well, I'm not going to lie to my loved one. I have a hard time going along with it. And that could be for any number of reasons. So I want to validate that if that's you, you're not alone. But one of the things that we think about is reframing this as a therapeutic fib or a loving lie, because the person's brain is telling them this is happening, this is real. And what we want is for them to realize who is around them and who they can trust and that they're safe. And if as the person they trust the most, you're going, no, that's not happening. No, 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 no. And their brain is telling them, yes, it is. That is often just leading to escalation. So if you have to say, yeah, Barnum and Bailey is in the backyard. Isn't that strange? Anyways, and then you move on. You are not doing them harm. You are not causing that hallucination to happen more than it otherwise would. You are not making things worse. If anything, you may be making it better. And there's one situation in which we tell people, if you can, and if this feels comfortable, it's okay to join them in the hallucination. What do I mean by that? They had a wonderful couple, and I bring up the circus thing because there was a couple and they used to fight every morning because the husband with Lewy body saw a circus out their back door going on every morning, 3 rings. And the wife would try to argue him out of it. And finally, she had this realization one morning of, it's not scaring him. Why don't I just ask him about it? I'll just go with it and join him in that reality. I can't see it, but it sounds like he's kind of enjoying it. So she said, all right, she would make the coffee, she'd make breakfast, they'd sit down and they'd look out the back window and she'd say, what's happening in the circus today? And that became their morning ritual. So sometimes people will see a pet from childhood. Instead of saying, Bingo's been dead for 50 years, that doesn't help anything. Oh, Bingo's here again. What did you used to do with Bingo? What was Bingo's favorite snack? right? Oh, well, where'd you used to go? Did Bingo ever go on vacation with you? It does not harm anyone, and it may help. So, number one, do not argue. You will not win. You will not win the argument because you're not arguing with your loved one. You're arguing with Louie. So we are running so far over time because I want to share all of these things with you. So I'm sorry. I will try to speed up on things. But as mobility changes, there are different things to know. So there are different assistive devices that can help with people who are ambulatory, who are walking. A cane is almost always a bad option, because a cane requires mental energy, even if the person isn't thinking about it, to put it, am I putting it on a crack? Am I putting it here? Which hand am I holding it in? Is it safe? All of this, we don't want them having to give that precious attention to a cane. We want them giving precious attention to balance and movement. So a walker is almost always safer, and not all walkers are created equal. But what this means is Medicare covers one walker every 5 years and one wheelchair every 5 years. And they do not specify whether the walker that they will pay for is the relatively cheapy silver one that they might send you home with from the hospital, or a fancy tricked out U-step like in the corner of this slide. What we want is to save that Medicare benefit for the fancy tricked out version. And if we need a cheaper version, for example, a transport wheelchair versus a custom fitted wheelchair that will prevent pressure wounds, we want to save the Medicare benefit for the expensive one, okay? Because they will only cover one of each every 5 years. If you use Medicare benefits to get a walker, you can use your Medicare benefit to get a wheelchair in that same 5-year period, but you cannot go the opposite direction. You can't get a wheelchair and then get a walker. Why? I don't know. I didn't make the rules. So for lightweight devices, things like that, ask around, see if a neighbor has one collecting dust in their basement. There are lending closets all over the country. You can search for them, often houses of worship, village town halls, things like that have a lending closet. People donate something they're no longer using, and then you can rent it out. Or looking online can be much, much cheaper. But for those custom heavy-duty devices, Medicare. And you don't need to figure it out on your own. Many healthcare institutions have a seating or a wheelchair clinic where the person is evaluated for, are they really tall? Let's get them a wheelchair that fits. Are they really tiny? Let's not have them swimming in one. Do we need it to tip backwards, to tilt in case their blood pressure drops? They've got those, but we need to be in the right place to get the right one. What else can be helpful, and what else do we need to think about? In terms of cognitive changes, our neuropsychology colleagues are incredible. They can evaluate people, not only what we typically think of is, I'm going to get a cognitive test and it's going to tell me what's changed, what's worse. Yes, and it will also tell us what's good and what's strong. So neuropsychological evaluations, if anything, are sometimes even more helpful to say, you know what, this has changed, but they're still really sharp here. So we're going to try to leverage that and find compensatory strategies to help people with those areas where they're strong make up for the areas that are declining. Other things to know. This is sort of a potpourri slide, but if a loved one has hallucinations, delusions, or agitation, call your local non-emergency line for your police station. If you can't find it by Googling online, call 911 and tell them you're trying to reach the non-emergency. It's okay, and they will transfer you. It is okay. And you're calling to tell them, here is my address. There is a person here living at this address who has Lewy body. They won't know what that is, but you can tell them they have hallucinations and delusions and agitation. Can you flag this address so that if you are called, you approach with caution? Please, 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 something to think about. Along those lines, there was a study that came out back in 2020 that said in the US, 50% of older adults age 60 and over live in a home with a firearm. If you have a person with Lewy body in the home and you have a firearm in the home and your loved one has hallucinations, which often are that someone is threatening their safety or the safety of their family, please, please consider additional safety precautions. There are some great resources. There's something called firearmlifeplan.org, I believe, that we can share with folks that's really helpful for that. And if the person is impulsive, if they're unsupervised, if there have ever been episodes of issues or safety in the kitchen, if you have a gas stove and the person is alone in the house by themselves, just take the knobs off of your stove and put them away while you're gone. Unplug the microwave. We've had people set fires because they accidentally microwave something with metal. Installing different locks on the doors so that the person cannot accidentally wander out of the house at 3 a.m. We don't want it to be that it happens once and now we know. We don't want to risk that once even. So if there are concerns, think about it ahead of time, including different medical alerts and different tracking systems are available. Where do I find these things? I forgot. I was so smart. I put the Firearm Life Plan in here, but also All's Store is one resource that has a lot of different safety devices and things like that. It's also got like fidget toys and different things that can be really helpful for people with dementia. If you find something on here, sometimes you can find it for a better price elsewhere. So I often use this as a idea generating and then price shop elsewhere if you have the time. Traveling. We talk a lot in our clinic, and people will tell us, well, we were supposed to go to wherever, but that's off the table now. And the question is why? Because there are many ways to make traveling easier. The key concept here is energy conservation. If you have a family wedding to go to, that is, 2 time zones away, spend the energy on the wedding events, not getting to and from. So even if the person doesn't usually use a wheelchair in the airport. There's no reason not to. The service exists. People are there to help. You will get through TSA way faster than any of the rest of us. You will get on the plane and off the plane much smoother, and you don't have to worry and you don't have to stress, and the person with Lewy doesn't have to. And if they are less stressed, they will be better for the actual event. So save the energy for where it's important. People with Lewy body can fly. They can go on cruises. It just might look a little bit different. It might take a little bit more planning and creativity and flexibility and acceptance of help. But we really don't want anyone saying, I was going to, but now I can't because of this. We've gotten people ice fishing. Okay, so this is a really cool organization that's out there that I've learned about in the last year called Hidden Disabilities. It's hdsunflower.com. It is free. You go on there and you register, and they will send you a lanyard that has a sunflower on it. And basically, in different airports and other places all around the world, staff are trained that if they see this lanyard with a sunflower, that's their quiet signal that that person needs some extra help or extra TLC. So you don't even have to say, hi, could you please help me? My loved one has this. Nope. You just roll up with your lanyard, and hopefully they're trained, they're seeing you, and they can help. Time zone considerations. Crossing time zones is really hard. It can lead to more disorientation for people with Lewy body. Plan ahead. If you've got a 2-day wedding, don't get there the night before. If it's possible, feasibly, logistically, financially, build in an extra day or 2 on either end. Give yourself time to get situated. That will help. If you're going, we've had people that, they'll go to Europe and they're going to visit, 17 different places. Don't do that. Pick 5 in the same amount of time and spend more time in a smaller number of places. That way there's less confusion. There's less, which hotel am I in? What city am I in? Where am I? If you need more tips for traveling, a shout out to Brain and Life magazine, which is brainandlife.org. There are a bunch of different articles about traveling with loved ones for a neurologic condition. All right, we're going to move on to planning and thinking about end-of-life concerns. So here is what we know, is as Lewy body progresses, caregiver burden, I use the terms caregiver, care partner, carer interchangeably. The strain, the burden on you rises, and it is already higher than for comparable care partners in Alzheimer's disease. The motor symptoms of the person with Lewy worsen. The hallucinations, the dementia symptoms become more frequent and worsen. These are the main causes of hospitalization. That UTI that I harped on, I'm not kidding. The pneumonia, the falls, the dehydration, the neuropsychiatric symptoms. These are all risk factors for hospitalization and for being placed in a nursing facility. And caregiver strain alone is a risk factor for being placed in a nursing facility, which is not to say, oh my God, but my loved one is in a nursing facility. What did I do wrong? Nothing, nothing. For many families, that is absolutely the best choice for them. It may be the only choice for them, and then it is absolutely the best choice for them. Everyone's situation is different. And there are many facilities out there that may do a great job. However, what we know from research is that when we look at all comers, individuals with Lewy body who are in a nursing facility have higher mortality compared to similarly aged people without dementia and even similarly aged people with Alzheimer's. And there are lots of different reasons for this. So as we get into this, we're going to launch one quick poll to talk about how do we plan for the future. So our first question is, has your loved one completed any advance directives, such as a healthcare power of attorney, a living will, a do not resuscitate order or DNR, or medical provider orders for life-sustaining treatment? You are all so fast. All right. So about 7%. That's much lower than I expected. You are all amazing. You all get a gold star. Your advanced placement already. 7% said no, they have not completed any of these. You are not alone. 30% said yes, they've completed at least one, but not all of these. And 63% have completed all of the above. Guys, you should be teaching this. That's amazing. So what are advance directives? Advance directives are legal documents that basically delineate, they explain planning for the future. So this includes something like a durable power of attorney for healthcare. That is who I want making decisions for me in the event that I cannot. And to be clear, signing a healthcare power of attorney does not mean now that person makes decisions. It just means that in the event that I cannot, that's who you go to. Okay, so it is never too early to have a healthcare power of attorney. A living will is what I want. And ideally, you've got both of those, and the healthcare power of attorney knows what the living will says, because they're the ones that has to make those decisions and not the decisions they would want for themselves. The healthcare power of attorney should be making the decision on behalf of the person, what they would want. And a medical practitioner order for life-sustaining treatment, that's a mouthful, which is a MOLST or POLST, is a shorthand advance directive for emergency situations. So people often talk about a DNR order or do not resuscitate. That is a small piece of this. So if we look at, this is just an example of the Illinois MOLST POLST form, and it really is a stepwise thing, okay? Okay, so what does it ask? The situation in which this is used is a person is not in a hospital. They are not in a healthcare situation, and they are found down. So the care partner, wakes up in the morning and their loved one is not responding to them. And you call 911. The paramedic comes in. They are going to check for a pulse. And if the person does not have a pulse, meaning that their heart has stopped, they have died. This is section A, is do we attempt to bring them back? Do we attempt to resuscitate them, or do we not attempt to resuscitate them? Do we allow the natural course to happen? That's question A, and that's a black or white question. And saying attempt resuscitation means yes to chest compressions to try to restart the heart. If that fails, yes to electrical cardioversion, to zapping the heart with paddles. Yes to putting a tube down the throat to try to get an airway and get them oxygen. That's what saying yes to that means. The other situation is the paramedics show up and the person does have a pulse. Great. Now what? So here, this is, we want everything done. Take them to the hospital, stop short of nothing. If they need lines everywhere, put lines in everywhere. If they need mechanical ventilation, a tube down their throat to help them breathe, do it. If they need to be in the ICU, do it. That is full treatment. The opposite end of that spectrum is comfort measures only, which means Maybe they've got a pneumonia, they're coughing, there's something going on. I want them to be comfortable. Give them oxygen. So comfort measures does not mean do nothing, stand around and just watch them suffer. That is not what that means. That is never an option. Comfort measures means oxygen, suction, getting the crud out, making them comfortable. And there is a middle ground. So sort of selective treatment or limited treatment, which means, yes, I'm okay with going to the hospital. I'm okay with getting oxygen by nose, but I don't want to be intubated. I don't want a tube down my throat. I'm okay with, IVs and things, but I don't want a big central line. I don't want to go to the ICU. You can set some guardrails, choice with guardrails, right? And then there are other questions about artificial nutrition and things like that. So what do we think about a MOLST or POLST? We need to have these conversations. We need to make these choices. The person has to sign it, the patient has to sign, or their decision maker, their healthcare power of attorney signs. But this is actually an order for medical things. So it has to be signed by a healthcare provider. If you have this at home and it's not signed by a doc or an advanced practice provider, it doesn't count. It's just a piece of paper. And it has to be active, so it has to be easily accessible. If it's in a binder in a file cabinet somewhere, I promise the paramedics do not know to go look for it. They know to look on your fridge. That is where this is supposed to live. And if it's not on your fridge, you put it in a Ziploc bag in the freezer. I'm not kidding. Paramedics are trained to open your freezer and look for a neon sheet to find this. So this can be completed after the other advanced directives, ideally, or this may be the form that helps start that conversation. It's neon so you can find it, so the paramedics can find it. And it has to be someplace where they know to look. If you don't want to stare at it every time you go to open your freezer, that's okay. Put a sign that says, POLST is located in kitchen drawer number 1, and label that drawer, right? You can put it somewhere else, but indicate, because that's where they're going to look for it on the fridge. Make sure that the healthcare power of attorney has copies. Make sure that if there are adult kids, if there are other family members that need to know, that they have copies. If there's a backup person, if there's a phone tree in case of emergency, they've got copies. Save it on your electronic devices. I mentioned this could be the start of a conversation. Having these conversations, not when a person is fluctuating, but having these conversations in those good moments. And it might take multiple conversations over time. These are really hard conversations to have, and you don't need to do this alone. So there are guardrails for you. Here are 2 examples of websites that I really like that walk people through having these conversations. And particularly the conversationproject.org has a program for how do you talk with someone with dementia about these issues. So you don't have to come up with this on your own. Who else can be helpful are elder care attorneys. These are attorneys, these are lawyers who specifically have an interest in helping plan for the future. So this may be the person who helped complete a financial power of attorney. That's the person who makes money decisions when the person with dementia no longer can. They can help do the forms for healthcare power of attorney as well. They can help work on a living will. And they can also help plan for future living transitions. They cannot help with a MOLST or POLST form or a do not resuscitate form. So before we talk about this, we're going to launch another poll. So you already told us about whether you've completed advanced directives for your loved one. If you are a care partner, have you completed them for yourself? You guys are so fast. It's looking like about a 2/3 split, which is pretty good. It's about 65% of people, yes, you've completed this for yourself. A third of folks have not. I would strongly encourage you, if you have to be in this space and thinking about these things, as hard as it is to think about this, and as much as we think it's too early to think about these things, it always feels too early until it's too late. And if you are that care partner and something happens to you, you want to know. Often what I hear from people is, I'm not worried about what happens to me. I'm worried about what happens to her, to him, to my loved one. The best way for you to have that insurance policy is for you to have your stuff in order too. And we hope that it's not needed, right? But for you to have who's making decisions if it's not me. And if you're married, if you're, in a relationship, the default position is that the spouse is the default decision maker legally. And so that may have been great, but maybe now with Lewy in the mix, the loved one really shouldn't be your decision maker anymore. So it's important to take a look at it periodically and make sure that whatever you've done before still holds up and is still what you want. And then we always encourage people to revisit their healthcare power of attorney and their living will every few years or after major changes or setbacks. And updated copies should go in the binder if there's a binder. It should go to the decision makers. It should go to your healthcare providers. I can't tell you how many times I ask people, have you thought about, what you want for the future? Have you made plans about all this stuff? And people are like, oh, yes. I'm like, oh, could I have a copy? Because then I could try to help make sure that we're all on the same page and following that plan. And sometimes it just doesn't occur to people to share those documents with your healthcare team. Please, on behalf of your healthcare team, please share those with us. Please bring copies, not the original. Please bring copies to your office visits, scan them into the chart. Your healthcare team can do that. If you use an electronic medical portal, you might be able to upload it as an attachment. But we want to make sure everyone involved knows what you want, what your loved one wants, so the whole team can be in alignment with that. Before we move on to the next topic, one of the things people say is like, where are we and what are the red flags that we need to watch for? And although this still requires so much more research, here are the things that in my own palliative clinic, these are our red flags. And this is borne out by research, which is repeated hospital stays, especially if it's for severe infection or for sepsis. That's a big red flag that we've entered a new phase. Repeated falls with fractures or other injuries, head trauma, subdural hematomas where someone's bleeding into the brain, unintentional weight loss, especially if body mass is dropping below 18, repeated pressure wounds, or sleeping for most of the day. Those are things that should make us think about hospice, because those are things that tell us that this person might be in the last 6 months of life. So with that, we will launch one more poll. How familiar are you with hospice services? Not at all. I've heard a little bit, but not very familiar. Or I have past or current experience with hospice with a loved one. Amazing. So over 50% of people have said, I have past or current experience. We didn't ask how that experience was, so that would be a different poll. 41% said I've heard a little bit about hospice, but not very familiar, and 4% said not at all. So let's talk about what hospice is. Hospice is part of Medicare. It is part of your insurance benefits. You are entitled to it, period. It is medical care and support for a person with serious illness and their caregivers when curative measures have been exhausted and life prognosis is less than 6 months. Well, I wish that we had curative measures in Lewy body. We do not. And I just told you that prognosis is really hard. We don't have any hard and fast rules. So really, when someone is referred to hospice, it should be because their treating provider says, this is actually in the terms, is I have a reasonable amount of certainty. So basically, I think there's a 50% chance that this person might pass in the next 6 months. If that is where we are, then you should be entitled to receiving hospice services. You are owed hospice services. It's not something extra. It's part of what you are owed. And the services that are mandated are an interdisciplinary team of professionals who are experts in end-of-life care. They can provide home medical equipment and supplies like incontinence supplies, wound care, oxygen. They provide medications. They provide what's called continuous care, which is very, it's not exactly what that means. What they mean by continuous care is there's a 24-hour phone number and someone will answer. A nurse, a physician, someone will answer. And if there's something going on at 3 a.m., you can call and they will talk with you and figure out what do we need to do. They offer equipment such as a hospital bed. The team varies, but often it's a nurse and a social worker checking in weekly or so. They provide medications, but it is not just a continuation of whatever the person's already on, because hospice gets a certain amount of money per person per day, and they have to make that amount stretch, and it's not nearly the amount that we would want it to be. So things that are just there for the long term and are preventing the heart attack, the stroke 20 years from now, like a cholesterol medicine, those are typically stopped. We don't need those anymore. We don't need all the vitamins and supplements anymore. We keep the medicines that are actually impacting quality of life right now. So before anyone is referred to hospice, ideally, things to know are that because it is a limited amount of money, most hospice agencies do not provide physical, occupational, or speech therapies. So those have to stop before a person goes into hospice. You can interview different hospice agencies, even if a loved one is in a hospitalization and the decision to move to hospice is made while you're in the hospital. They'll say, oh, we're going to send someone to meet with you. And each hospital may contract with a particular agency. You do not have to go with that agency. If you get bad vibes, move on. You have every right to speak with someone else. Ask them. You can interview them. What do their services look like? What does the team look like? Who actually visits? How often? How consistent are they? Is it a different nurse every week or is it the same nurse, barring vacations and illnesses? What else do they offer? What kind of bereavement support do they offer? As part of those requirements, they are required to offer bereavement support for at least 13 months after the loved one passes away. Why 13 months? Because the anniversary is particularly hard and they realize that. Ask them if they have experience with Lewy body. Really, ask them, get in there, ask for details. Ask whether they will communicate with the referring physician. Here's a great website, americanhospice.org. This gives you more questions that you can ask. So the really important thing to know is that hospice does provide that nurse and social worker weekly. They provide supplies, they provide the 24/7 number. You have access to inpatient respite, which means if there is a family wedding and your loved one truly is at a point where they cannot go, your loved one can be admitted to inpatient hospice for up to 5 days, and they will be fully taken care of so that you can go. You don't need a wedding as an excuse. You can just say, I need to tap out right now. I am at my wit's end. I am having health issues. I need out for a moment. I need help. 5 days of inpatient services. But what hospice does not provide is paid caregiving. Thinking about hospice, one of the hard things, and I encourage you to take a look at Dr. Armstrong's talk, but also take a look at any of Dr. Armstrong's work because she is an expert certainly in this area. Things that we start to notice in the final weeks to days of life are sleeping most of the day, having only brief moments of alertness with minimal or no speech, minimal food or fluid intake or just refusing food or fluid, limbs or digits, fingers, toes that are they're feeling cooler, looking bluish or kind of mottled or lacy looking. People may start to get pressure sores when they didn't have them before. Irregular, rattly sounding breathing. And then sudden, new, or worsening agitation. So what do we do? That's when it's really helpful to have hospice already on board. This is not when we want to be calling hospice in. Ideally, we want hospice on board for 6 months. And what happens at 6 months if the person is still alive? We recertify with hospice. Okay, no one kicks you off. So hospice can say, I'm worried that we're getting to transitioning. We're getting towards the end of life. That's when you invite people to come over and visit. Not all at once, maybe. The folks who are far away, invite them to call, invite them to video conference in. Let them know that they may do all the talking, and that's okay. What are they supposed to talk about? Anything. Reminisce about activities that they used to do together. What was the favorite thing that you did? Share a positive memory, tell a story, read a book, read a story, poetry, play music that they enjoy. Anything, any of that presence we think is therapeutic. Hopefully it's therapeutic for the person with Lewy. Hopefully it's therapeutic for the care partners, and it's therapeutic for family to have some closure. Play calming favorite music in the background. Light massage, holding hands is great. Make sure you care partners are eating and sleeping, as hard as that is. If you're involved in research, if your loved one has consented to brain donation, this is a time to consider notifying those teams. I think we're in the last few days, just as a heads up. What not to do? Do not push foods or liquids. If the person is pushing them away, is refusing, their body is telling them something. We don't want to fluid overload them, because if they're taking that in, it may actually build up around and in their lungs, and that may be a worse way to go. That may increase suffering. Leave the TV on at all times? Especially not with the news, especially right now, because anything going on that's stressful can percolate. Even if the person doesn't seem like they're fully conscious, it may be percolating and infusing any hallucinations or delusions and making things more frightening. And don't place any expectations or judgment on how you will feel when the loved one passes. We talk with care partners all the time, and we have folks who tell us, I'm so ashamed, but I felt a sense of relief. Because maybe for them, the end was even, the end was just so difficult. For many people, they experience anticipatory grief. You're grieving for the person that they were, even though they're still physically here. There's a sense of ambiguous loss where you don't get to have that closure. You don't get to have the conversations you wish you could have. So you may have already been grieving without calling it that. And when the end finally comes, there may be a sense of peace. And it may feel like our societal expectations are, but I'm supposed to be tearing my garments and and crying and sobbing. And if that's not how you feel, that's okay. You are allowed to feel however you feel. And there are people to support you. So, wrapping up, there are so many support groups out there. You got to find the one that's a good fit for you. So start somewhere. Start local or regional, ask your healthcare team. Go to lbda.org. They're amazing. They support groups all over the country. Check out all the different foundations. We have so many people and so many wonderful foundations. You can pick and choose from them all. Okay, so spotlighting the Lewy line, they're amazing. The folks who staff it are amazing, and there's so many additional resources and links. The Davis Phinney Foundation, I've been lucky enough to work with, and we created a care partner training program. Although that is focused on Parkinson's, almost all of it still applies. It's free. Leverage those friends and families and neighbors who are saying, how can I help? If you need something, let me know. And you never know what to actually ask them. Make a list. Make a list in your phone, on a piece of paper, on the fridge, wherever it is. Make a shareable list. All the things. And you can divvy and delegate these out. It doesn't matter if you feel weird asking someone to do your yard work. They want to help and they don't know how. Give them something concrete to do. Lean on our faith communities. If you're part of a spiritual tradition or a faith community, reaching out to that community. They may have friendly visitors. They may have offers of transportation to get you or your loved one to the church, the synagogue, the mosque, wherever it is. They may have someone who will come sit with your loved one to be able to watch Mass virtually. And these are folks where they often will help with meals, with all kinds of other stuff. It takes a really strong care partner to ask for help and to accept that help. Be that person. There are memory cafes. There are adult day programs. Sometimes we don't know that these exist right under our noses and in our neighborhoods until we start looking. But start looking. Start looking before you might need it. Look to local Alzheimer's groups, because I will tell you, 85% of people with Lewy body are misdiagnosed or undiagnosed before they get to being told that they have LBD. So there are going to be a lot of people in your local Alzheimer's group who are going through similar symptoms, and they don't even know that that's what's going on. And you may meet people, and you might be the educator. If you are in a rural area, I didn't know this, many USDA extension offices have dementia programs for rural areas. Our hospice agencies can be tremendous sources of resources and referrals. And finally, death doulas. These are individuals who are not healthcare professionals. These are lay people who like helping families during this difficult time of transition, being another person there to help to ease the transition, to offer comfort. And you can find death doulas actually all around the country now. Last, I'm going to quickly say something about peer mentoring. So I have been fortunate enough to work with hundreds of amazing Lewy body care partners over the last, I don't know, decade plus of time. And we started an intervention now 6, 8 years ago, where we were doing home visits for people with very late Parkinson's and Lewy body. And we knew that that alone was not enough for our care partners. We knew we needed to do more for our care partners. So we recruited experienced care partners and we said, would you just mind once a week talking with the care partners to these really late stage homebound folks? Just have a chat, be a shoulder to cry on. You get it, you've been there. And lo and behold, they did. And it worked and people liked it. And so we moved that forward and we did another study called Learning to Persevere. And LBDA helped us with this. Parkinson's Foundation helped us with this. We did focus groups of care partners and we said, what do you want to know? Maybe there's enough out there and Uncle Google is helpful enough and you've got the information that you need. But if not, what would you like to know? And what should it look like? And oh, did they tell us. So we built a curriculum. We made it entirely virtual. We partnered with our foundations. We trained 36 experienced Lewy body care partners to be mentors from all across the US. We recruited 30 newer caregivers who were in the first couple of years of their loved one having cognitive symptoms to be mentees. We matched people up as best as we could. We're not quite Tinder, but we did what we could. And we gave them this curriculum that they helped create. And we said, just talk with each other once a week for 16 weeks. Use this book if it's helpful, but if it's not helpful, don't use it. Just talk. And what we found was, lo and behold, not only were people so busy, but they prioritized doing this. So this was a small study. It was just 30 pairs of mentors and mentees, but 100% found it useful. 90% of our mentors said, even though talking about all these things might be hard, might be triggering, 90% said, I will do this again. And 50% of our earlier caregivers said, you know what? I'm ready to pay this forward. I'm ready to be a mentor to someone else now. And both our mentors and our mentees improved their knowledge of Lewy body, and our mentees improved their attitudes towards caring for a loved one with Lewy body. So I am beyond excited to share with you that in partnership with LBDA, with Parkinson's Foundation, with a core of 6 Lewy body care partners who have advised us every step along the way, this is open now. We have a national, first of its kind, entirely virtual, randomized control trial of this Persevere peer mentoring support and education that has been specifically been designed by and for Lewy body care partners all across the US. If you are in a US territory, we've got you. We are waiting for you. Send us our folks from Guam and US Virgin Islands. We're ready. If you look at this map and you see that you're in a light blue or a gray state, we really are ready for you. California, Texas, Illinois, Florida, you guys have shown up big time. Thank you. We're still looking for more people. We are recruiting over 680 Lewy body care partners. We are over 500 right now, which is amazing. And what this is a weekly Lewy body specific curriculum for 12 weeks, and then we follow people up for about 6 months. If you are an experienced care partner, if you have lost your loved one, you could qualify as a peer mentor, and we will train you and support you to support a mentee. If you are in the first 3 years of your loved one having cognitive symptoms, you would qualify as a caregiver, and the caregivers are randomly assigned half and half, but everyone gets something. So some get a peer mentor assigned to them, some get the lighter intervention, but the lighter intervention is still education that's been designed by and for you over 12 weeks. Everything is virtual. It's all on your own time. If you are interested, you can zap the QR code, you can click on the links, you can email us. We are also, because our care partners told us, we are on TikTok and Instagram now, offering tips and tricks and life hacks and things. So with that, having gone so far over time, as Lewy body progresses, symptoms often increase in number and severity. But there are many, many things that we can do to ease discomfort and help quality of life. Any sudden change, think infection, think dehydration, think new problem, not Lewy body. Do not just sit on it. Do not just wait. Seek help. Lewy body causes apathy, hallucinations, delusions, agitation, and dramatically altered sleep patterns. This is not your loved one's fault. This is not your fault. No one is doing anything to make this happen. This is Louie's fault. Go scream into a pillow, go use your choice of four-letter words, and then try to maintain a daily schedule and offer choice with guardrails. Do reassure, redirect, use those therapeutic fibs and relaxation techniques, but whatever you do, do not try to argue. It won't help, it will make it worse. Use lending closets, find lending closets for your basic walkers, transport wheelchairs. Use your Medicare benefits for the bigger, better, more expensive stuff. Talk about goals of care and complete advance directives, not only for your loved one, but for yourself. Keep those documents accessible, keep them up to date, and ask for help. Recognize the wisdom that you have and the wisdom around you in the community and seek it out and connect. So with that, I am so sorry. I told Julia I would run late, but not this late.
Oh my gosh, thank you so much. So that was absolutely amazing. Look at all the love you're getting from our community. They love it. Fantastic. If you don't mind to stop sharing your screen,
Oh, sorry,
do
I
you
thought that
have like a hot second for a question? I know you need to
I
go.
do. Yes, I think I got 10 minutes.
Okay, excellent. All right, we will make it quick, I promise. So, I'm kind of, putting some questions together here. One that we got that I thought was really interesting was when we're talking about advanced stages and going toward end of life. Some people were still really unclear on what that is. Like, what does that mean? And I think it's really nebulous. So, if you were asking people kind of how you define that, what would you say?
I mean, I think it is really nebulous and it really depends on the person. So, we have some folks where they may come to us and cognitively, their cognitive symptoms are really significant to start with. And they're kind of, progressing, but slowly progressing. But their movement symptoms were okay. But then we see that kind of, even though sort of things have been slow and slow and slow for a while, now we're in a period where all of a sudden in the last 3 months, the last 6 months, they're falling all the time. All, they're slowing down, they're freezing, all this stuff, where there's been sort of this change in the trajectory of things were getting worse, but they were getting worse relatively slowly, but now. And it's kind of taking that cue from the person and from the care partner, right? Whereas other folks, if they've got PD dementia, and that's how they're coming under the Lewy body dementia umbrella, they may have a lot of motor issues. They may come to me and already be wheelchair dependent, but they can still go to rock steady boxing and they can box something in a chair and do all this. And they were okay. But now suddenly the fluctuations are really bad. And we were, taking a nap in the morning and taking a nap in the afternoon. But now in the last 2, 3 months, we're sleeping 21 hours a day. We're waking up, we're eating a meal, we're falling asleep while we're eating, we're going back to sleep, we wake them up, we have another meal. That to me is that person is in late stage for them. Right? And I know that's a deeply unsatisfying answer. It's a deeply unsatisfying answer to me too. But
Absolutely, absolutely. I'm glad you mentioned that too, because I do think sometimes people get very frustrated by that. And I know I've said in so many meetings with amazing experts like yourself and our different working groups and committees who are also very frustrated and want to be able to give these answers, but you don't want to give people the wrong answer either. And so this is a really tricky part of this disease. Thank you for
and I
clarifying.
and I would say just a shout out is if we want those answers, if we want to have a staging system, participate in research. Please. I don't care which study. Literally, find a study, okay? Because especially right now, especially in the current climate, please, 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 so many studies fail because they don't enroll the number of people that they need in order to statistically be able to see whether whatever they're testing is making a difference. So go to clinicaltrials.gov, go to Louis Trial Finder, go wherever. Um, find something. If you're a care partner, you may qualify as a healthy control, although I have feelings about that. You may qualify and help explain things. So please, 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 we want the answers. The only way that we find these answers is by asking the questions, doing the research studies, and engaging folks.
Absolutely. Thank you so much for that. All right, so we had another question come up that you and I talked about last week when we met a little bit, which is this concept of people being wheelchair bound and unable to move. And so one of our attendees commented that, like, wow, when I go to help my wife with things, her legs are really strong. Her
Yep.
upper body can move. So, like, why is she immobile? So, can you comment to that?
Yes. So the brain is really complicated, is the very, very simple answer. So there are parts of the brain that control motor strength, and there are different parts of the brain that control intentional movement. So you can be 100% strong and yet unable to use those muscles in the way that you want to. So we often hear people will say, my loved one can't push themselves up out of a chair. They don't have enough strength. They feel too weak, but I'll get them up in the bathroom and then they get the death grip where they're up and I can't get them to sit back in the chair. And you can see them like the biceps are, right? And like all of a sudden they're Superman strength, right? And so that strength is there all the time. And it's not that it's sometimes they're choosing to use it and sometimes they're not. It's that their brain's ability to plan movement is impaired. So that's where it's coming.
Absolutely.
We test
And
in the we'll test and say, pull your arm, do this kind of stuff. We're
yeah,
testing for that strength that's there, but that doesn't mean that you can use that strength the right way.
and that's where you guys, I love that she gave a shout out to physical therapy, occupational therapy, LSVT Global. Like these are clinicians that can really help you with movement strategies. Because I have to tell you, I wish I had a dime for every time we had someone come in who was immobile and wheelchair bound, and we stood them up and we were able to get them to move. But we're also movement professionals. So get those people in to help you, and but not saying they're going to be up walking around or doing marathons, but a lot of times there is mobility that you can do as well.
And
All
if
right,
you
we'll
saw
make this.
saw a
Oh, go ahead.
therapist and it was like a therapist at the like franchise physical therapy chain on the corner, and that was not helpful, that does not mean that therapy is not going to be helpful. That means that you saw someone for whom their bread and butter is bum elbows and bum knees and sports injuries. They
Good
don't
point.
know anything about this. They don't have the training. So you're right, it wasn't going to be helpful. Go to someone who knows before you say that
Absolutely.
it's useful.
Absolutely. Just like you wouldn't go to an orthopedist for your Louis, right? You're not going to go to an orthopedic physician. You're literally seeing a lot of times an orthopedic therapist in a lot of those settings. So they don't know about your nervous system. Good point. Good point. We'll make this the last question because I know you have to run, but I think it's a really valid one. So, feeding tubes. When do you think about this or consider this? Actually, I have one more question after this. I lied. When do you think about or consider a feeding tube? How do you know? Like, what should you do?
It's a really good question. And I think this also is very individual. So this is something, to think about ahead of time. And if, there are folks who have very, very strong opinions and they're like, no matter what, under no circumstances would I want this. If that is truly the case, then put that down, right? Document that, make sure that people know that. If someone is having a hard time swallowing, if they're at risk of aspiration, right, that's when we want to go get a swallow study, see the speech language pathologist, figure out what can we do about this, because they may be choking, they may be having issues, and there may be things that we could do, right? Um, our research shows us that for the most part, it doesn't look like feeding tubes extend life in Lewy body, and it doesn't look like they improve quality of life, right? And so if something is not extending life or improving the quality of the life, the time that you've got, well, then what's the point, right? And so that's often where we land, is that this may not make a difference. And it is a tube. It is something that is coming out of the wall of the belly. It can be a source of agitation. Someone can see it and
Mhm.
pull it. There's all kinds of stuff. There are a few situations in which we might consider it, though, which is where, for example, someone, wasn't having issues, but they had a bad aspiration pneumonia. They're in the hospital. They get a swallow study in the hospital, and they're not safe to swallow, which means nothing is getting in, including medications. And that may
Mhm.
be a time where putting in a temporary feeding tube, which is different. That's a tube that goes in through the nose, down the back of the throat, into the gut. to get meds, to get nutrition, to get over whatever temporary hump is happening, that may be appropriate. And if it looks like they're, person is gaining strength, they're doing better, and that tube gets pulled and then they're fine, awesome. If in the worst case scenario, we repeat the swallow study and they're not getting any better, then usually those kind of tubes can really only stay in for about 2 weeks, 3 weeks max before we start to worry about scarring and injury. But that gives
Mhm.
us kind of a 2 to 3 week period to say, okay, this is where we are now. Do we want to go to a permanent feeding tube? Do we not? So sometimes we have folks where their swallowing is really severely affected really early. Everything else is okay, relatively. That might be someone where actually in that case, yes, a feeding tube makes sense. But if severity of all of the symptoms is kind of tracking together, that's where it usually doesn't make sense.
That makes sense. Thank you very much. And you guys definitely consider checking out the webinar that we had last year with a speech language pathologist about swallowing issues. And I believe she does touch on feeding tubes in that as well if you want more information. Last question, I promise. So, with the cognitive changes, as someone's advancing and maybe decision making, how do you address, changes or talking to your loved one when they're maybe not okay to make decisions about placement or memory care or things like that? Do you have any suggestions?
I think it really depends on the person, sort of when we say like that they're not in a place to do that. There may be people where, in certain moments they absolutely, don't have good insight. They can't make those decisions. But maybe we catch a good day, we have a good moment, and even though it feels like I don't want to use a good day or a good moment to talk about this, think about it as that's an investment in their future
Mhm.
happiness, quality of life, is to say, things are getting really difficult at home. I'm noticing that this is getting harder, this is happening. So often it's not framing things as like, I think we might need a caregiver to come in. What do you think? Would you want that? That kind of puts it to a person as like, that's up to you, right? Whereas what you're really saying for most people, if they're at that point, is this cannot continue the way things are. And so one option would be, if it is available to you, right, is bringing in help into the home. One option would be being placed in a facility, right? And so I think it's really hard because none of those are good options. It's not necessarily what anyone wants, right? But it's saying, this is what we need to do. Is so that you are safe. So, we can do all these things together. A little bit of a would you rather. And if truly the person can't do that, I think then it's kind of thinking about 5 years ago, 10 years ago, if you would have had this conversation, or if they were part of conversations about other family members who were having issues, right? Did you ever have to talk about the in-laws or, grandparents' generation and what was going on with them and what was their response to talking about, a nursing facility then? Or what experience, did they bring in, which maybe you never talked about in relation to them, but can you pull from anything in the past to say, I think if they could tell me now, this is how they might feel about that.
That's really, really good advice. Thank you so much. And Jori, with that, I know you need to get going. So I will finish and do our outro. But everybody, go ahead and please use your reactions to give a warm thank you to Dr. Fleischer for sharing her time with us today. Really appreciate. I know we went over substantially, but you guys, this is such a complicated topic, as you could see. And I think you covered it so well and so beautifully. And this may be one.
I don't know if it's just me. I just lost your sound, Julia.
All right, excellent. And so with that, guys, oh, there you are. You're back. It looks like your video froze. So we will see you next time, Jori. Thank you. So on behalf of the LBDA, I would like to thank you all for taking your time out of your day to join us. And again, thank you to Dr. Fleischer. As a reminder, you're going to receive an email in about 1 week with the link for the recording of the presentation, as well as the resources and links that we talked about in today's webinar. We invite you to visit our landing page on the website to stay informed about the upcoming webinars and access those past recordings. We talked about a lot of those today, and Rose will drop that link in the chat now. And our next webinar was actually kind of alluded to by Dr. Fleischer on Tuesday, August 12th at 2 p.m. Eastern Time. We're delighted to welcome Dr. Kate Wyman to discuss the topic of apathy in Lewy body dementia. We thought this one was complicated. We're going to take another complicated one next month. Dr. Wyman will provide a comprehensive overview of apathy in LBD, discussing the symptoms, the impacts on patients, and current research findings. But then we're also going to be joined with a panel of living experts. So individuals and care partners who are living with LBD as they share their personal experiences with apathy as well. Rose is dropping a link for that registration page now. Finally, please take a moment to complete that survey that's going to launch when you help leave to inform our content. We look forward to seeing you in August, and thank you again for taking time out of your day. See you soon.